Okay, where are we at here? Okay, fluid overload is deadly. Can I have the clicker? Thanks.
Sure.
All right. So we should avoid the term fluid overload. Here's a diagram of your, basic normal physiology of a 70-kilo man with a body weight of, and you take that, multiply it by 0.06, and you get your total body water content. Now, this is a normal sized person, not obese, not, a normal Texas sized person. This is more of a, I guess, this Southern California person. Okay. Of that 42 liters, 28 liters of that is intracellular. So the majority of all of the fluid the water that we are made of lives in the intracellular space. You have some in the cell membranes, and then there's approximately 14 liters in the extracellular fluid. Of the extracellular fluid that we have, 10.5 liters of that in this patient is in the interstitial space. And then you have red blood cells, but the plasma and plasma water, everything in the plasma, the liquid portion of our blood, is 3.5 liters. So if you add the red blood cells into that, assuming a hematocrit of, let's say, 45, then, let's see. I'll get it to work eventually. I think we're dying here. Next slide, please. Then our circulating blood volume of that patient is going, here you go, is going to be about 5.2 liters. All right, next slide, please. So how does the water stay where it belongs? Well, it's a balance between osmotic and oncotic forces. Continuous exchange occurs between the intravascular space and the interstitial spaces, and the intracellular compartments and extracellular compartments. Focusing on the intravascular space, however, the total proteins and albumin is 70% of your, basically your 60 plus percent, almost 70% of your total protein content in your blood. That's why it's used as a surrogate for knowing whether your patient is hypo or hyperoncotic. Is the driver, but cellular exchange is largely ionic in the intracellular, extracellular movement of water, and osmotic in that case. But in the extravascular space between the blood vessels and the interstitium, it's predominantly oncotic. Okay, next slide, please.
So, Joe, can I stop you right there?
Yes.
Because you touched on something. You touched on something that was dear to my heart. Mm-hmm. You just, correct me if I'm wrong, you said the albumin, percentage of albumin, protein percentage is about 60 or 70% of the total protein is albumin. So I just want to point out something. When people prime with albumin and they think that they've cured the problem of diluting out our protein levels, and we basically have become even. You still have 30% of the proteins that you're diluting. Mm-hmm. You're not adding any of those. You're not adding the globulins and all the other ones.
Correct.
So we're doing a lot by doing that. I'm a big advocate of it. But you still have, and this is a good example of it, many other things that are even on pump with albumin, mannitol, plasmolite, with the isonconic electrolytes. We still have things that are trending towards third space.
I totally agree.
And that's one of them. 30% of the proteins, other than albumin, are still being diluted down to probably 30, 40% lower of what they should be.
That's a very good point. And I think a lot of people don't even realize what the percentage of albumin is for your total protein, and how and I think we grossly underappreciate it. Look, I'll say this as a sort of a precursor to the rest of this discussion. you can take a normal, healthy individual and that, was otherwise healthy, 50-year-old, routine, 2-3 vessel cabbage, whatever, isolated mitral valve or aortic valve or whatever it is, or a healthy, athletic, younger woman who needs something similar, and do just about anything to them, and they're going to be fine. There's those outliers and anomalies and things that happen at curveball. You go, what the heck happened here? But basically, everything we're discussing really comes down to the sicker of our patients, of which, of course, I've been in cardio. I've been involved in perfusion since 1977. So I'm probably the old man of the sea here. I need my parrot on my shoulder. But back then, we started off with the patients who were just horrible. But it sort of evolved like the late 70s, mid to late 70s into the early 80s to where, I never did anybody that was over 50 years old or 55 years old. It was cabbage. We did valves and stuff like that. But predominantly our patients were much, much younger and much, much healthier than they are today. Our cases have become much higher acuity. They have many more multi-organ system dysfunctions going on, way more diabetes, way more heart failure, way more anemia, all of the kidney disease, pulmonary disease, whatever you want to, all of this. And their nutrition is worse. Their albumin levels start off way lower. It's a totally different patient. And so these talks, my talk here now is not about me having to do you, because I could just about do anything. I could probably flow 1.5 liters and you'd probably do okay. But, if you had to do me, you're going to be I want you to flow a little more than that and be a little more stressed. I'd be stressed only because I love you. But if I didn't know you, your case would be a chip shot. I'm going to be a bigger challenge.
In 1985, when I got into this, age 72 and over was contraindication for open heart surgery.
Mm-hmm. Mm-hmm. Yeah, I remember the first time we did an octogenarian. It was written up. I mean, they had the New York Times, calling, wanting to know about it.
Mm-hmm. I remember very early on, we listed all the indications for cardiac surgery and the contraindications, and one of them was age 72 or older, contraindication for cardiac surgery.
Mm-hmm.
Wow. Think that's changed a bit?
Yeah, just slightly. Okay, so back to my slides. Back, okay. All right, so let's see. Here we go. Let's see if it's going to work. Is it working, fellas? Just go to the next slide for me, please. We're at the very beginning. There we go. So here's an interesting article. How does the water stay where it belongs? Okay, this article here, and I believe it was out of England. It was published in Perfusion. A good article. But in this article, the authors discussed hyperosmolar primes, putting mannitol in the prime, and the concern was that if you create an immediate hyperosmolar state, when you go on pump, that you can cause potentially osmotic demyelination syndrome. And of course, we know that's bad. But and I'll say, however, hyperosmolar states are created every day for closed head injuries, for example, by giving the patients massive amounts of mannitol, hypertonic saline. You drive the sodium up to 150, 100, even higher sometimes. And both hypertonic saline and mannitol are used. So very frequently, this reduces the intracellular water. So on a closed head injury, for example, you want to make the intracranial pressure as low as possible. So you give this in order to shrink the brain, basically all of the cells of the brain. Mm-hmm. And typically, demyelination syndrome occurs when you have a sodium below, I believe it's 120, and you rapidly correct the sodium to get it back up to 138 or 140. I have to say, I think the paper was a provocative paper and thought out well, but I don't necessarily think it is germane to adding mannitol to the pump prime. I don't think, unless you just had 100% mannitol prime with nothing else in it, and maybe threw some hypertonic saline in with it, that you're at a risk of having that problem. I think having a somewhat hyperoncotic, hyperosmotic prime makes sense, because if I have to choose between shifting volume from the interstitial space into the blood vessels and maybe even intracellular to extracellular transiently, I would rather that than shifting it the other direction. I think there's less risk of longer term sequelae associated with that. Next, here we go, I got it. In regards to third spacing from a reduction in oncotic pressure, your plasma refill rate, PRR, is reduced and fluid accumulates in the interstitial space. That's what that is. So there's constantly a shift of volume of water and even plasma or albumin across your cell membranes and your vascular through the capillary system. And it goes out, but there's a pull to bring it all back in, and that's called your plasma refill rate. Albumin, though much maligned for seemingly no good reason, is very, very influential in this. And capillary leak syndrome, because I hear a lot of times, oh, we don't want to give albumin. Look, the patient is very third spaced. They have capillary leak syndrome. Well, capillary leak syndrome is not equal to decreased plasma refill rate secondary to hypoalbuminemia. Capillary leak syndrome is its own process by which, and it's an inflammatory process that causes this to happen, and it's devastating when it does. And in those cases with capillary leak, giving albumin would be the last thing you would want to do, because you give it and it just makes the matter worse because it leaks out. But those patients are in devastating shape, and it really requires a plasma adsorption or plasma purification technique to relieve the severe inflammatory response syndrome. Next slide, please. Go ahead. Next slide. Right there. So what does fluid overload look like? Does it look like this? Anybody? Does that look like fluid overload? It does? Okay, next slide. No, wrong. Next slide. Does that look like fluid overload? If you look at that, you can see that the heart muscle, it looks like it's stuffed, but it's swollen. It's almost, again, we've seen this before with very, very sick hearts. That patient has a right atrial line, an aortic cannula, and a right superior pulmonary vein line. So you wide into the venous line. So you definitely have look at the right atrium. The right atrium is flaccid, but yet look at the right ventricle. It looks stuffed, but it's not stuffed. Do you think that looks like fluid overload? Next slide. Bonk. No, it's not. What that is both of those examples are an example of third spacing, because the harsh reality of it is you can have a patient that looked like that lady or a heart that looks like this, and your lines, your access lines or venous return lines are chattering because you are intravascularly hypovolemic. So if you remember the title of my slide, what is fluid overload? And my next slide was we should not use the term fluid overload because it is not specific enough to what you are trying to describe. Is the patient hypervolemic, or is the patient hypovolemic intravascularly? And is the patient third spaced, hypervolemic in the interstitial spaces or intracellular spaces, or are they not? So that's really, you have to increase specificity and be more accurate in our description. Next slide, please. The fact of the matter is that both of those patients can be grossly hypovolemic. Next. The venous capacitance system, our venous capacitance system is a giant reservoir. Although it acts much more significantly than just a reservoir, has a lot of function to it. But 60+% of all of our blood volume is in our venous capacitance system. Next. So this is a very interesting slide, and it's a concept that I want to sort of get everyone to understand, because where I go from here, a lot of this foundation is going to be very important. So you have a mean systemic pressure. Now, that's not to be confused with a CVP. It's not to be confused with an arterial pressure or a mean arterial pressure. It is the mean systemic pressure. And how do you measure mean systemic pressure? Well, it is measured by stopping all circulation. If you stop all circulation, simply stop the heart, and this has been experimented on in the ICU with patients who were in the process of dying, where you have lines in various places within the vascular system, and the patient dies and all circulation stops, and then you get a pressure. All of the pressures throughout all of the blood vessels will eventually equalize and become a pressure. And that pressure is between 10 and 12 millimeters of mercury. That if your patient, assuming your patient, is euvolemic at the time. If it's a trauma patient and they've died from massive bleeding, then it doesn't, the test doesn't work. They have to be a normovolemic individual. So our mean systemic pressure is for us, is about 10 to 12. That's what it is. So if you look at this diagram on the left, this is a baseline. And you'll see that you have unstressed and stressed. And again, this is the venous system. Above it, you see the LV, you see the arteries, you see the vascular waterfall, which is your capillary bed. So let's now look at the venules to the veins and all the way back to the heart, your venous capacitance system, which is the round cylinders. What does unstressed and stressed mean? Well, if you took a waterbed, and I tried to I was going to do a demonstration with a balloon, but it wasn't working out because I didn't get the right balloons, but that's a different story. If you take a waterbed that's completely empty and you've set it up and you were to measure the pressure, it's pretty much zero. There's no pressure in it. There's nothing in it, right? But you start pouring water in it, but it hasn't yet begun to expand. That pressure is still zero. And you keep filling it, and eventually it starts to take some sense of shape. So now you probably got some pressure. But you keep filling it and keep filling it until it has reached a point where it is the shape it's going to be. It has reached a point of where it now has tension on it. That is the point by which you go from unstressed to stressed, because if you fill it more from there, then you start to actually stretch the material. So that would be your stressed volume. Well, think of your venous system, excluding your right atrium, as the exact same way. That system has to be full enough to have a stress. You have to have a pressure in order for there to be venous return. The higher your mean systemic filling pressure is to a point, because it has a point, just like the Starling curve has a point, you have a point, but the higher that is, the higher your venous return is. And therefore, higher your cardiac output is, up again to a certain point. You can obviously go then into heart failure, in which case the right atrium pressure starts to go up. So your gradient between your mean systemic filling pressure and your right atrium is what the driver is to get venous blood through the venous system into your right atrium to fill it, beat, empty, fill it, beat, empty. That's the gradient that you need. So if you were to deplete your intravascular fluid volume to a hypovolemic state, you will have inadequate venous return vis-a-vis our patient is empty, and we see it on bypass all of the time. But that can also happen through vasodilatory processes. Mm-hmm. So if you have a patient, which you would look at on the right, that has a venous capacitance system that now has been dilated, you will see that because of that dilatation, it's going to take more volume to fill the unstressed portion because you've made a bigger waterbed. It's not a twin size. You've graduated to the queen, and you're going to need more volume. But what really the thing that's most important is that if you don't change your volume, then what happens is the stressed volume pressure, the volume within your stressed system decreases, lowers your venous return, lowers your cardiac output. Next slide, please. So in this particular example, you see the right atrial pressure, which is on your x-axis, and your venous return on your y-axis. So as you take in the blue lines, move your mean systemic filling pressure to the right, which also does increase your CVP, though they are independent of each other. It's important to understand that. You see that your venous return goes up. So on the left, the furthest to the left is hypovolemic, then you have euvolemic, then you have hypervolemic. And this can be demonstrated all of the time with a fluid challenge. Our patient looks kind of wimpy with their blood pressure, so give them a challenge of 500 and let's see what happens. You throw 500 cc's in, you see an immediate improvement, and although that may only be transient, we could talk about the reason for the transient nature of it is because the fluid all now went out into the interstitium or because some other reason we don't know. But nevertheless, we see it, we fill the heart, we come off bypass. What do? We start filling it. We're not just filling the heart, we're filling everything. But, volume challenges can tell you whether or not you're euvolemic, hypo, or hypervolemic. Mm-hmm. Next slide, please. Here we see the mean systemic filling pressure on the y-axis, blood volume on the x-axis, and the center green dot is our control. And what I'm showing here is as you give the blue triangles, as you give an alpha agent, you see that you are reducing now the size of the tank. You're going from a queen back to a twin, and so your tank size has decreased given the same volume. What happens? Your mean systemic filling pressure goes up, and over all spectrums of blood volume. So you can be hypovolemic, but still have a better blood pressure because what you're doing is making the tank smaller. You can increase your venous return given a particular blood volume simply by decreasing the size of the reservoir. And then the same would be the case, for the opposite spectrum with the adrenergic blockers or vasodilators, which you see with the red dots. So below the control, but over a spectrum, they lower the blood pressure by lowering your mean systemic filling pressure. Let me see here. I got check your email for. Oh, okay, good. With the right parameters turned on. I just got a message that with the right parameters, the Siemens 500 blood gas analyzer can do those calculations for the talk on DO2. Mm-hmm. So thank you very much. I appreciate that, Kevin. Okay, let's see if this is working yet. Next slide. Next slide, please. Edema and fluid overload can be mutually exclusive. Although hypervolemia is always associated with some edema, edema is not always associated with hypervolemia. Next slide, please. Data supporting hypervolemia as a prognosticator of bad outcomes. CPB is highly dilutional. Inconsistent treatment of albumin, I think, is the norm today, surprisingly. Cardioplegia, dilution, depending on how much you give. And now with Delnito, we give a lot of crystalloid, more crystalloid than I think we did when we gave, when we used Pledgisol, frankly. Mm-hmm. And then arguments over pump, ultrafiltration on pump continue to seem to pervade. Next slide, please. Hypervolemia has been shown conclusively, and I want to say that one more time. Hypervolemia has been shown conclusively, not conjecturally, to be associated with a host of unfavorable outcomes, to include respiratory complications, neurocognitive problems, AKI and ARF. Again, AKI and ARF. This is hypervolemia, all right? Increased vent times, length of stay, increased cost, and increased 30-day mortality. And I put my references for that right there. Next slide, please. Here's a very interesting slide talking about fluid balance, assessment of fluid balance status and fluid responsiveness in the middle. So you have your optimum or euvolemic patient right in the center on the scale. Volume depletion, so hypoperfusion results in hypotension, shock, organ hypoperfusion, and AKI from ischemic disease. And then if you over-aggressively fluid resuscitate, you have impaired oxygenation, edema, hypertension, organ congestion, and although the slide doesn't say it, all of those things we know leads to AKI, okay? So optimum fluid balance is very important. I'm not advocating for hypovolemia. I'm not advocating for hypervolemia. I'm really advocating, and I think, use of the hemoconcentrator to become normovolemic is what I'm trying to achieve. I think all of us are, those of us that use it. Next slide, please. Okay, so this is a very interesting slide. The organs, cerebral edema. This is the consequences of fluid overload. Impaired cognition, delirium. For the myocardium, conduction disturbances, impaired contrast. I wonder how much AFib we are contributing to due to myocardial edema post-operatively. Impaired contractility, diastolic dysfunction. The lungs, pulmonary edema. It results in impaired gas exchange, reduced compliance. You got stiff lungs, increased work breathing. You can't get the patient extubated. Renal interstitial edema, reduced renal blood flow, increased interstitial pressure, reduced GFR, uremia, salt and water retention. That's the one with most problems. Hypervolemia, look at that list compared to the other. It hurts the kidneys more than anything else. Hepatic congestion, impaired synthetic function, and cholestasis. Gut edema, malabsorption, you get an ileus, tissue edema, poor wound healing, wound infection, pressure ulcerations. So these are all of the consequences of fluid overload in the various organ systems. Next slide, please. So this is very important. I really need everybody to read this, so I'm going to read it to you as well. Most people think there are a lot of bad people running around the world. There aren't a lot of bad people. There are a lot of bad ideas. And bad ideas are worse than bad people because bad ideas are contagious. Bad ideas get good people to do horrible things. Please, I'm going to ask all of you, you're all good people. It's a bad idea to not use ultrafiltration on pump. I'm just going to say it. So don't be that person, okay? Let's try to follow this logic. Next slide, please. The patient, actual patient, I say patient one's the only patient, okay? 72-year-old, you like that?
It's a big study.
Yeah, it's a big study. 72-year-old female, poor nutrition and sedentary lifestyle, 5'4", 78 kilos, EF is 40%, patient has 3+ MR from a dilated LV, 4-vessel disease. She's in for a cabbage plus mitral valve repair or replace. Next slide. Here's her chemistries and albumin 138, 4.6K, 101, BUN creatinine look good. I mean, she's actually, this looks like she has reasonably decent renal function, normal creatinine certainly. Total protein is 4.6, albumin 2.8, so she is a little hypoproteinemic and hypoalbuminemic. And by the way, does everybody know, you may know this, I don't know if you know this, but an albumin level of 2 or less is an independent predictor of mortality. Mm-hmm. An independent indicator of mortality is an albumin level of 2 or below. And I've seen albumin levels of 1.2, and they look like that lady with the water balloons on her eyes. Okay, hemoglobin 32, or crit 32, HNase 32 and 10.3. Next slide, please. Total circulating volume is 46 liters in this lady based on the calculation. Circulating should be 5.4 liters, but she's got MR, she's got ischemic heart disease. I gave her an extra liter, 6.4 liters. Extracellularly, in the tissues, I bumped her up from 16 liters to 20 liters to accommodate for most patients I see with ischemic heart disease that have an ischemic 3+ MR for any length of time tend to have pitting edema. So I'm just, taking that as a liberty and an assumption, if you will. Next slide, please. Heart rate's 100. This is right on anesthesia, just post anesthesia induction. BP 138/90. PA is 56/32. Not unexpected. CVP is 18. Not unexpected. So, I mean, these are pretty. This is what we see frequently. These are not unusual, really weird, unusual, bizarre numbers. But this patient is in some element of failure. Doesn't mean she's hypervolemic. Just means she's in failure, because you can have this presentation, interestingly enough, and you can have a very low mean systemic filling pressure at the same time. Mm-hmm. That's why using an echo to look to see if the patient is euvolemic or what their volume status is, let's say, or right atrial pressure, or SVC collapse, or what any of these other things, actually is not, it's okay. And that's a whole nother talk for another day. It's okay, but it ain't great. It's not really that perfect, but it's what we got. Next slide, please. Anesthesia volume for the pump, before pump, they gave 800. Our priming volume was 1,300. We wrapped 500. Even though I don't wrap, I don't believe in it. I think it's a bad idea. Again, bad idea. Bad ideas are, what that leads to. Good people doing really bad things. Urine output was 200. Cell saver was 100. Del Nido dose was 1,000. So taking everything we added up and subtracted, our total volume for the pump contribution to the patient's circulating volume is 2,900. The on-pump reservoir volume is now 3,400 cc's. That's what you got in the tank, okay? And you're flowing along, get good flow, everything looks good. Turn next slide. So how much is the patient now fluid positive? Okay, well, we really don't know, and we assume a lot because of the things that I just discussed. The CVP is 0, so we know the heart's empty. We've got plenty of flow, plus all the added volume is down the reservoir or refilling the venous capacitance system and restoring the PMS, or is it instead third spacing? We don't know the answer to that either. Next slide. Predicted crit is now 22, so I basically took the red cell volume, divided it by the now new total blood volume, and got to what would be the predicted hematocrit. We don't know what the COP is because we don't measure it. We didn't run an albumin or anything on pump, which we probably need to. But do we know where the volume is? What is the PMSF? What is the vascular tone? What is the status of volume in the interstitium? Again, we really just don't know. There are ways to know, but it takes work and it takes changing how we do things. Next slide, please. And it's not really that hard. So final thoughts. If you are not flowing enough in this patient to provide the required DO2 because of cannula size, circuit limitations, you're flowing what you think is enough, but you thought would be enough, should be enough, but isn't enough for whatever reason, and you're not flowing enough at this moment in time. Let's assume that. And there's nothing mechanically wrong. The patient has 3,400 cc's in your reservoir. You can't flow anymore because you overflow your cannula, but it's just not enough. Okay, that's the scenario. You have a normal SVR. Okay, so you have normal vascular tone. You've corrected your COP to have a normal plasma refill rate. Now you've given albumin to try to deal with that. It was in your prime, let's say. The patient is not making much in the way of urine at that moment. You have 3.8 liters of volume in your reservoir, and you remove 2.8 liters of that with ultrafiltration. Again, from an open reservoir, we use an open system. Even a bag is kind of an open system. It's not truly an open system, but it's still an open system because it's a displaceable reservoir, right? And you raise your crit from 22 to 28, increasing your O2 content per vols percent. Therefore, your flow being the same, you're now delivering more oxygen to the tissue under that scenario, and you still have a liter of volume in the tank. Okay, plenty of flow. Tell me how we're causing AKI. That's my question. My question for anybody that can answer that question for me and calls in will get John's houseboat. Doesn't matter who it is. Call in. You'll get it. You'll get cups. You'll get something. I'm telling you, you will get something. You'll get a free trip out here. You'll get a free, if you can convince me that anything that I just discussed or described causes AKI, help me understand that. I'll wear a man bun for the entirety of the next show. I'll do whatever you want me to do. I don't care. No, but I'm going to get a stick-on man bun. They have them. I'll get one. So next slide, please. Redneck murders are hard to solve. There are no dental records, and all the DNA is the same. Okay, any questions? You don't have to stay focused on that slide. You can change. Oh, do we have Keith here? I see Keith in the background. Keith, where are you? Hey, Keith.
Hey guys, good morning.
Hey.
I don't know those two new panelists, but hi, John, and
that's Tammy. I'm glad to, Tammy, and that's Min Tran, Tammy Sparacino, and Min Tran. And y'all, that's Keith Smolik. Mm-hmm. You know Keith from Global Blood Resources. Mm-hmm. He's the hemo bad guy. Yes, Tammy knew you.
Not personally.
All right, Tammy, thank you. So anyways, yeah, great talk. I can't deny anything that you've said. I think it is so important that a lot of people don't pay attention is that every single thing an anesthesiologist does to you tends to dilate you. And what are anesthesiologists taught? Volume, volume, volume. Mm-hmm. Instead of trying to get that SVR back to normal, they're all taught to challenge the Starling. So give volume test, volume test, volume test. But we all know that it all floats back out Thirdspace, So the key is to have a normal SVR and a good color osmotic pressure. So you're drawing that fluid back in on the venual side. So, hydrostatically on the arterial side, it's pushing it out, delivering all the nutrients and oxygen and all those good things. But on the venual side, if you don't have a good color osmotic pressure, it's not going to go anywhere unless it's pulled back in. Now, normally, you and I and everybody sitting around here, we have a system called lymphatics, the body's natural sewer system. But that's paralyzed because it only works with skeletal muscle movements. Everybody's paralyzed on a table. So until they get that tube out of their mouth, their lymphatics is essentially paralyzed. So it really boils down to good SVR, and good colloidosmotic pressure. If you have those two things, you can help regulate that volume a lot better. Third spacing that fluid a lot less.
Very good point. Very good points.
Yeah, I was telling Joe, I guess it was last night, we were talking about the way I've always learned about it and the way I've always read about it. And what I believe is that the instant we go on bypass, you automatically have several strikes against you when it comes to third space for several reasons. One, you just brought up a very good point. Your lymph system, which takes your interstitial fluid and naturally returns it slowly back into your venous system, is really not working very well, if at all, because you're paralyzed. Number two, not fully understood, but a non-pulsatile flow automatically tends towards third spacing. So if you do go on bypass and you've added things to your prime to where you're just isoosmotic, you're still going to third space because of those two reasons. The non-pulsatile flow allows for more vascular permeability, and your lymphatic system is not returning the natural fluid that it would normally bring back. So it almost tends you to think we should be a little bit hyperosmotic on bypass just to keep from third spacing.
You don't want to cause that demyelination syndrome.
So here's an interesting thing. When I went to work at my first job, they were having their routine patient was 10 to 15 pounds overweight in the ICU. And we did have a lot of volume, a lot of cardioplegia volume. I was very aggressive with the hemoconcentrator, and I was only there about 6 weeks, new kid out of school. And one of the surgeons came up to me, "What are you doing to my patient?" I'm like, "Oh, geez, now what have I done? What are you doing to my patient?" I'm thinking, "What have I done now?" He says, "My patients are only 2 to 3 pounds overweight." I've never seen that before. We've always had patients here 10 to 15 pounds overweight. I said, "Well, I'm just removing a lot of that volume on pump." So it was actually a very good thing. But let me ask you this. Have you ever had a patient come off of bypass who was weighed less than when he started? I've never heard of that.
No, probably not.
Right. So even all of our efforts, prime with albumin, mannitol, maybe some people do the hemoconcentrator. Maybe I've seen people prime with Lasix. I don't know if anybody's ever had a patient weighed less in the ICU than they did in the OR. So even over all these efforts, they still third space. They still third space. So that's
a very good point.
You're at war with this third spacing, the way I look at it. So, it just automatically wants to happen. And we have to try to reverse that, because the third spacing, it's not just going into the feet and the hands, it's going into all your organs too. And this is going to decrease your time in the ICU is going to be increased. Extubation time's longer. Your cardiac function on inotropes is going to be longer. Your ICU stays are going to be longer. And the patients that I did this with, all were discharged a lot quicker from the ICU because their functions were better.
I agree. And I think a lot of people also underappreciate how significant interstitial edema is at reducing microcirculatory blood flow. Mm-hmm. So as you continue to third space, you start creating essentially a global, if you will, parenchymal, the organ itself's compartment syndrome, where you are increasing the pressure on the microcirculatory system, making it very difficult to flow through it. What are your guys' thoughts on ultrafiltration, volume statuses? What's your experience been? What do you think, and what has your experience been in terms of managing these things with the other clinicians you have to work with?
I agree. Like, as soon as you go on bypass, the patient, gets all these inflammatory responses. You have all this increased permeability and all those spaces, and patient gets fluid overload. So you definitely have to stay ahead and, try to get that, oncotic pressure up and, give albumin and, replace it. I think that's why I'm an advocate of wrapping, because, the less hemodilution I can, hit the patient with, then I think that's going to save the patient from losing red cells and, losing, diluting that albumin and proteins.
Mm-hmm. Mm-hmm. You're not a bad person.
Well, let me just interject something.
Bad idea.
Joe, let me just
But the patient still, I'm not taking the volume away from the patient. I'm just reducing the fluid that I'm giving to the patient because the blood is still going to, go back into the patient as soon as I go on bypass. I'm just taking a much
borrowing it.
Well,
borrowing
it for a few seconds.
So think about this for a second. If you're a person who loves low prime volume, we all do. If you're a person who likes wrapping, you should be the biggest fan there is of hemoconcentration because it does both of those things. And it removes inflammatories, which wrapping doesn't do.
Of course.
But
So,
don't you think a combination of ultrafiltration and wrapping needs to be done together?
No. She's tricking you.
No,
She's tricking you. Think about what she just said. You don't believe in wrapping, do you?
Well, I think you should do it to a small extent because, listen, for 25 years of millions of dollars of research went into, can we make this arterial line filter 25 cc smaller? Can we make this oxygenator 50 cc's less of prime? Can we squeeze some out of the heat exchanger side? Everybody was focused on lower primes, lower primes, lower primes. Here's a technique that doesn't cost a dime to do, and you can decrease your prime by 300, 400, 500 cc's, and it takes no expense whatsoever. Didn't take hundreds of millions of dollars of research to invent a new device. We just do it. So, I think you should do it. It's there waiting for you to do. But why are you doing that? What he just said, Min, is correct. You're not going to dilute the patient. You're keeping your osmotic pressures up. You're not diluting your hematocrit. So hemoconcentrator does all those things, and it removes inflammatory. So you should probably wrap to some extent. Now, you're opposed to people wrapping when it starts to cause ST elevation or ST depression. That's really your biggest concern.
I think if you have to treat the patient with neo, if you have to treat the patient to give them a blood pressure because you are making them so hypovolemic while you do this, then I believe that the risk-benefit ratio is imbalanced to too high of a risk. And especially when I see them going backwards through the arterial line, retrograde through the arterial line, again, I think although maybe only a small risk, but air entrapment into the arterial line or some other incident occurring while you're doing that, to me, is not worth. I just don't think it's worth the risk because what do we wrap? 500 cc's, 600 cc's? I can go on bypass. And while I'm going on ultrafiltrate out 500 cc's, before the blood makes it down the venous line all the way and back up to the end of the arterial line.
If you have vacuum on it.
Huh?
If you have vacuum on it.
Yeah, of course. I always put vacuum, but I always put vacuum on mine.
Oh, okay. Not a lot of people do that.
That's how I ultrafiltrate. I turned it on the Neptune at max back. Okay, I get serious about this.
Yeah.
So, Keith, what's your thoughts? I'm anti-wrap. They're pro-wrap. I think just ultrafiltrate it off as rapidly as you can, and the almost momentary at best 500 cc in out is inconsequential. Plus, I think you're kind of doing a flush. But go ahead.
Okay, so I am a proponent of wrap and VAP. What I've seen, or what I was taught back many 15 years ago, was to do it very, very slowly through your stopcock, connected to the cell saver. So basically you had a line going off of your manifold that went to the cell saver, and you could control how much with the stopcock, how much fluid was coming down, how much fluid was going forward. And we use the arterial filter as like the promontory pass. So we would take a little bit of venous blood, and then we would shuttle it all the way out through the arterial filter to the cell saver. And then once we got to the arterial filter, we stopped. And we moved the clamps, and then we did arterial back to the arterial filter. And essentially the entire circuit, I'm not lying, essentially the entire circuit was primed with the patient. Now, do you need to give some neo? Unfortunately, yes. Sometimes an anesthesiologist needs to play ball with you and give a little tiny bit of neo in order to keep that pressure up.
Well,
but what happens?
It's more than just a little teeny bit of neo, number one. And number two, here you're telling me that you're taking a patient, so you're accepting hypoperfusion for however long this takes you to do this versus a transient period of time of getting a 1,000 cc's, maybe. You could maybe wrap just the venous side. But I mean, you're going all out here, and for what? I'm sorry, I didn't mean to interrupt you, but go ahead.
Okay, so like I said,
I'm going to convince you otherwise.
Well, I'm open to everything, as you know. So the deal is, I told you before, anesthesia does not play with the they let it dilate out. So they've got a patient they think is okay, but really it's, 800, 900, 1,000. It's not 1,300 where it should be, okay? So they do need to tighten the patient up a little bit because everything that they've done is dilated the patient, including giving them a lot of fluid. Mm-hmm. There are 2 papers, one that I sent you by your cell phone, which is really important. And then, of course, there's the classic one, the Chappelle article on fluid balance. Pop that up real quick here. Chappelle's paper, it says, a rational approach to perioperative fluid management. This guy wrote this paper back in 2008. It is still the gold standard of fluid management for anesthesia and surgery. The other paper that I sent you, which is really important, it just came out in the fall, is early negative fluid balance is associated with lower mortality after cardiac surgery.
Yeah, there you go.
And that was, again, that was in JEC. Or no, it was in perfusion. And basically, their conclusion was this observational study indicates that a negative fluid balance is associated with lower postoperative morbidity and mortality in critically ill patients in cardiac surgery. Yeah. Bingo. Yeah. I mean, it doesn't get any better than that. So again, this 2 days of talks that you guys have been doing on fluid balance, everybody needs to clue in, again, having a good collar osmotic pressure and a good SVR. Mm-hmm. If you get those 2 things, you're not going to lose so much fluid third space. You won't give so much fluid. You won't get into the spiral where you need to give blood products and everything else. And then, of course, the absolute easiest things to follow patients is weight change and how much chest tube drainage.
I know we've gotten
those are
from that.
They cost. How much do those things cost? They're free.
Yeah.
So I've got 2 people that are doing studies right now, and that's some of their observances is how much weight did they put on and how much chest tube drainage. Again, cost nothing. Those are just observational things. The goal, obviously, is not to give people hemodilution is the enemy. Some people say, oh, well, we dilute these people out. We what is that? ANH. So yes. They take fluid off the patient so that they can have it at the end of the case. Yeah. Oh, the platelets aren't beat up. Well, guess what? About 60 to 80% of those platelets are still functional in the pump blood at the end of the case.
Yes.
So why would you think that the blood you drew off earlier than that was going to be any better?
And the blood that you put in the bag has lost probably an equal amount of them just by being in the bag.
Yep. And even though they rock it for a couple of hours and this, again, I don't want to poo-poo it because there are people that swear by it, but I still say that if you do all the other things, and again, it's not one thing, it's everything, multidisciplinary, multimodality, and that's what works. I always said it was easy. We would treat a lady who was 60 kilos, Jehovah's Witness in the morning for an AVR, and her crit was, let's say it was 35, coming in the room, but we never gave her blood products, not at all. But in the afternoon, we had another 60-year-old woman or, a 60-kilo woman, and her crit was 37, but somehow she got blood. We just didn't pay attention as much. We didn't watch like a child, how people hover and everybody watches each other. You want to treat every single patient like they were a Jehovah's Witness with a small BSA. And if you can do that, you can avoid giving blood products to almost everyone.
Mm-hmm. I think that's a very good point. I think that those are all very good points. Okay.